Remember that suctioning is an airway part. To suction, we want to clear the airway. So we do this with oral suctioning or nasosuctioning. We do this to clear blood, secretions, vomitus, anything that's in there. It's used in a vacuum to create the suction, or you have, like this, you would have a portable suction. All right? This works actually quite well with this portable suction. I'd rather have this over this when we look at the suctioning. So when you look at the different components, we'll look up here. Well, let me just go to this picture. I think it's next. Yeah. We'll look up here at this picture, and we have on this portable electric suction device. I used to have one of these, and during our suctioning class, I burned the motor up. Just to let you know how much we suction. I burned it up. And I felt bad because your parents paid like $500 for it. These are very expensive. So I'm working on something different for this year for suctioning. But you have a battery-powered portable suction, or one that's like this, that's a hand. You squeeze it and it suctions just the same way. Here you have the suction canister and then the suction tubing, and then at the end of that suction tubing you have some sort of device, an adjunct to help you suction. All right, that we'll look at in just a minute. But the thing with suctioning is, on the tip, when you look at the tip, it has to have the big bore on it. One of the suction devices is called a Yonkers tip, and it has a very small bore on it. So you're not going to get anything big up in that. This, however, you will. You can get something quite big, and it creates a lot of suction.
You put that in that hole, right?
No, well, we're not talking about tracheal suction, oral suctioning, mouth, right? So in a sense, it does go into a hole. And OS, O-S, that's one of your abbreviations, O-S. OS means hole. OS, the mouth isn't there. So
It
you,
means,
huh?
it means
Hole.
hole.
So you have a suction device like this, and then you have, like you see in the hospital, you have mounted suction devices. So there's quite a few different kinds, fixed or portable. Primarily, you guys will do the fixed one. This first device is called a Yonkers tip, suction tip, and it's also a hard tip suction like this. So Yonker, if you can say that weird word, or hard tip, it's the same thing. Hard tip, remember? And I'll pass this around for you guys to look at, and notice the diameter of the hole. So this, right away, you want to know what that's for, and you say, well, not too much is going to go through that small hole, and they're right. This is what I started trying to suction that big loogie up with, and it got about to the bend, and it wouldn't go any further because it just wasn't big enough. On this particular Yonkers tip, you have a hole there. You have to have a vacuum in order to suction, just like your vacuum cleaner, right? Vacuum. So in order to create a vacuum with a tip like this, you have to cover it with your finger. Some of the Yonkers tips are solid, so they suction continuously once the unit is turned on. Right, so it's a bent type suction, and I only used this like 2 or 3 times, so it's fairly clean. But you put it in if we look at this picture here, there's a way to measure it, and you measure the Yonkers tip from the ear to the tip of the mouth. And you sort of put your finger there. I've got a short video to show this in a minute. You put your finger there so you don't put it in too far. But suctioning, you want to go all the way back until the oral pharynx. So you suction all the way back. You suction on the way out, not on the way in. So you see where you want to go and suction, and then you put the suction catheter in, then you start suctioning. And it's not really a large bore. It's really more of a smaller bore suction device.
Yep. Oh my gosh.
So section only what you can see. Don't lose sight of the tip, and be careful about the gag reflex. Let's make a note right here for right now that a vagal stimulus, all right, a vagal response is a slowing of the heart rate. So one thing that you will do, you have a time limit on suctioning, which is between 10 and 15 seconds. Some of the books says 10 seconds, some say 15. So 10 to 15 seconds of suctioning time, or that if the patient's connected to a heart monitor, you watch the heart rate. Because what will happen here with this vagal stimulation is the heart rate will start to drop. Once the heart rate starts to drop, you need to stop suctioning. Once you remove the suction catheter, like the Yonker, it will take away the gag or the vagal stimulation, and the heart rate will come back up. Then you can start suctioning again. Now, if you're suctioning and there's still stuff back there to suction, and it's been longer than 10 or 15 seconds, but their heart rate hasn't dropped, you can continue to suction. But once the heart rate drops, you need to stop suctioning. Now, for testing purposes, the amount of time suctioning is 10 to 15 seconds. I'll try to, if 10 and 15 is on the same answer, I'll probably throw it out or try to change it before that. But so 10 to 15 seconds. Remember that vagal stimulation, a vagal response, is something that slows the heart rate down. We will talk about vagal stimulation a lot when we get into sort of a cardiac section. But for now, just right down there through the side, it's a decrease in heart rate is what happens. The other suction catheter that we have is a flexible suction catheter. And these are primarily used, like if the patient is clenched or something, you can go in the side of their teeth or you can go down the nose, do nasal suctioning. The suction tubing goes on this end, and then the hole, you would just push it in there and put it over the hole and pull it back out. So you have a soft tip for a flexible suction. And you can see that this diameter, this, is really small. So you're limited there. I don't have the right suction tubing. I meant to pick some up yesterday. But the suction tubing has a larger diameter. You can use that suction tubing to suction with if you need a larger diameter as well. There's nothing wrong with taking the soft tip or the hard tip off and using the tubing if you need something with a larger diameter. Or you can use the portable suction. You can see the diameter of this. I mean, that's big. So that would work out quite well in something larger. What about the beanie weenies or the hot dogs that's in there? They're not going through this or the suction canister. What are you going to do with those? Huh? Pick it up. Now, we don't put our hands in people's mouths because we end up looking like this. They bite the finger off. Then you have another airway obstruction. But you're right. If there's like a big hot dog back there, I would take this suction board, go back there and get on top of it and do that and try to pick it up. If this wouldn't do it, then I take the tubing and try to get it out with the tubing. Otherwise, I'd have to do something else to get that out. All right? To pick it up. I had a guy that went in cardiac arrest shortly after his meal, and it was apparent to me that he did not chew his food because he had beanie weenies for lunch. And when he threw up, because one important thing that I'll go over again in CPR, it's not if they throw up, it's when they throw up. When he threw up, the beanie weenies were together. You could, if you wanted to, you could, once I plucked them out of his back of his throat, you could put them in the hot water, reheat them, and eat them again. They were almost cold. You know. But So there is problems. You still have to clear that airway obstruction, right? So you're going to have you don't have to fix that. You don't have to come up with a solution for that problem. And also the flexible or a French suction device. You can have these in larger bores, but that particular one that you're looking at is rather small. They kink, they won't suction large secretions. They get clogged up very easy. So it's only for the last sort of resort thing if you've got someone's clenched down, like having a seizure and their teeth are clenched together, or you're going down the nose. When you guys get up and practice this in a few minutes, then you'll see how it sort of works. When an OPA we'll go into later, but we'll look, and it's measured sort of the same way as an OPA. On this suction tip, you measure from the tip of the ear to the tip of the mouth, and you put your finger there, and that's as far as that you go in. So your fingers are sort of the marker on the depth that you go in to suction. You don't want to go in too far because you start trying to suck their epiglottis out, right? You don't want to do that. And like I said, no more than 10/15 seconds. This will cause hypoxia, which is a new word for you guys, I think. Hypoxia is the lack of oxygen to the cells. So lack of oxygen, hypoxia, or bradycardia. We know about bradycardia, the slow heart rate. And they get this bradycardia through a vagal stimulation. Right? So if they start to brady out, then you would stop suctioning or just use that time limit there.
What's hypoxia again?
Hypoxia is the lack of oxygen to the cells.
And what is bradycardia?
Brady means slow, cardia. So bradycardia, slow heart rate. Bradycardia by definition is a heart rate less than 60. Okay. So you look in the mouth, you see where you want to suction, you go in, you mark it from the tip of the ear to the tip of the mouth, measure it, go in, find out where you want to suction, put your finger over the hole if there's a hole there, and then suction on the way out for no more than 10-15 seconds. I think we'll go with 10. Let's go with 10 seconds. So we won't have 10 to 15. Let's go with 10 seconds for suctioning. Now, in your mouth again, start to distribute.
This skill is demonstrated with 2 EMTs. If applicable, check the pump to ensure it can generate a 300 millimeter of mercury vacuum. Battery-operated units should be fully charged at all times. Turn on the power. Place your thumb over the end of the suction tubing to ensure the unit is working. Attach a catheter to the end of the suction tubing. Measure the distance from the corner of the patient's mouth to the earlobe, and place your fingers at this mark on the catheter. Insert the catheter into the patient's mouth without using suction. Insert the catheter until the tips of your fingers reach the patient's lips. Apply suction by turning the unit on or occluding the hole in the catheter, and suction for only up to 15 seconds at a time to prevent the patient from oxygen deprivation. If you cannot clear the patient's mouth in 15 seconds, log roll the patient onto his or her side immediately to allow the fluid to drain from the mouth and clear the oropharynx. Intermittently suction water to clear the lines of the tubing.
A log roll is just a method of rolling the patient over their side. It's just log roll, just a coordinated effort. So you roll the patient to the side in like a recovery position. So everybody good on suctioning? Any questions on suctioning? Very good, pretty easy. We'll practice the skill. Once I get the suction brew, we'll practice it a lot. So when we look at the airway, to keep the airway open, we say definitive Definitive means what? Definitive. So absolute control of something. You have definitive control of it. Absolute control. Definitive care. Definitive control of the airway. That is called intubation. Now, you guys are not allowed to intubate, obviously. All right, that's an advanced life support thing. But I want to show you intubation, because what happens is, remember those facial responses. It happens every year when what takes place. You see a patient being intubated. And they're putting that breathing tube. They're putting an endotracheal tube. Endo meaning inside, right? They're putting a tube inside their trachea so they can breathe for the patient. That is definitive care. Because what happens with the endotracheal tube is there's a balloon on the end of it, and they blow that balloon up, which occludes or blocks off the trachea. So if they do happen to vomit, it's not going to go anywhere. It's not going to go down their trachea because of that balloon sitting there. I'll show you that during lab. We'll look at that. Most of the time, you guys will be breathing for the patient using the bag valve mask with someone that's on an endotracheal tube. So we'll walk through that in a little while, probably a few days, and so you can practice breathing on an endotracheal tube. But this video here shows you the process of intubation, because I've seen students in there where they're putting the laryngoscope blade in their mouth, and all of a sudden the student's mouth like dropped to the floor, and the family member looks over at the student and like, what are they doing? They're just so shocked about that procedure. You go to the student, pick their jaw up, and say, you're scaring the family member, because they haven't seen this. It's not your fault. You just haven't seen it. So that's why we go through it, so you'll be familiar with it.
Before attempting to intubate, you should check all your equipment. Lock the laryngoscope blade into the handle and test the light. Several sizes of endotracheal tube should be available. Test that the cup is intact. A malleable stylet allows the endotracheal tube to be bent to any desired shape. Don't forget to check the suction. Proper head position will improve visualization of the larynx. Leave the head in the neutral position if there may be a neck injury. Otherwise, elevate the patient's head on a couple of towels and extend the neck. Hold the laryngoscope with the left hand and open the mouth with the right. Gently slide the blade into the mouth, being careful not to pinch the lips or the tongue against the teeth. Insert the blade on the right side of the tongue, displacing the tongue towards the left. An assistant can retract the right side of the mouth and improve visualization. Cricoid pressure sometimes brings the larynx into better view. Advance the laryngoscope blade down the midline until the epiglottis is visualized. For a curved blade, slide the tip of the blade above the epiglottis until it stops in the vallecula. For a straight blade, the tip of the blade lifts the epiglottis. Pull the laryngoscope in the direction of the handle to expose the glottic opening. Do not rock the blade against the teeth. Advance the tube from the right side of the mouth, keeping the glottic opening in view. Tip the tube up and in, advancing until the cup just disappears beyond the vocal cords. Placement of the tube in the trachea must be confirmed, preferably with detection of carbon dioxide.
So you can't talk or that, can you?
No, once the tube is in place, you can't speak. That's correct. And this patient was unconscious. The part where the jaw drops out when you first see this is when they stick that big blade down their throat. They're going, oh my, because it looks sort of hideous. I'll show you here in class so you'll be sort of familiar with it and go, okay, intubation. When we talk about it, the advanced things that we talk about in class is what you see in the hospital. So you understand, it gives you greater understanding once you see that. You know what they're doing. That's important when you see something that you know what they're doing. If you don't know what they're doing, then ask, right? Just ask questions about it. We spoke the other day of the pediatric airway. Just remember, there's some anatomical differences between those. Smaller mouth, nose, huge tongue. The trachea is very flexible. It can be blocked off very easily with improper movement of the head. Did you see that head tilt chin lift? How much they adjusted that head on that last video? A child's airway needs to be in a neutral position, or what's called a sniffing position. So you wouldn't do a head tilt chin lift on a child because of the narrowness of the trachea right through here. You would block that off. You would close the child's airway off. So a child or a pediatric airway needs to stay in a neutral position. When an adult without trauma, atraumatic, A without, right? Atraumatic would be a head tilt chin lift. So you can sort of see the differences in the anatomy here versus the adult. The pediatric airway is a lot harder to control. You have to be more precise in all the different movements as well. So don't hyperextend the neck. Make sure that you, just like all the other adjuncts that we're going to learn about, that you measure them correctly. Again, don't measure the suction device. Be very careful in suctioning with pediatric patients. The last thing that you want is a pediatric patient and their heart rate to drop. You never want that to happen. So you have to be extra careful in suctioning that you don't activate that gag reflex and cause their heart rate to drop. Everybody good on suctioning? A little bit on the intubation. We'll talk more about that when we get into CPR.
I think I missed it, but what is the pediatric position?
So what?
Pediatric.
Sniffing
No,
or neutral.
definition of that word. Pediatric. Like job.
Oh, the pediatric patient, an infant is from birth to 1, and then a child is from after the age of 1 to 8 years old. And we'll learn more about that in CPR.
From 9 to what?
8
8.
and above is an adult, considered an adult. All right, so let's go into the next things that we're going to measure. One of the first things that we'll measure in respiratory emergency is the SpO2. SpO2 stands for partial pressure of oxygen in a capillary bed. So everywhere that there's a capillary bed, we would measure SpO2. In short, this is telling you that this is the percent of oxygen in their blood. It's not quite that, but that's the sort of the best short definition for right now. Is the SpO2 is the percent of oxygen in their blood. Now we're going to change that definition up as we learn more, because the SpO2, by definition, the way it says there, is the partial pressure of oxygen of the hemoglobin in the capillary bed. But you can cut all that short by, for now, saying it's just the percent of oxygen concentration in the blood. That'd be good for now. The way that the normal SpO2 is 95 to 100%. You measured the SpO2 with a pulse oximetry device such as this. This one clips on the finger. They have other ones that have wires. This happens to just be a portable one. They have other ones that have wires attached to them. I'm sure if you've seen in a hospital or anything, they have some that tape on there. But you can attach this anywhere where there's a capillary bed. You can put it on the toe, the finger, You know, like a lot of pediatrics, they tape it to the ear. So, I mean, there's capillary beds all over the body, right? So commonly this is put on the finger. You have to not have fingernail polish on because it won't read correctly. But, so you just place it on the finger, turn it on first, and then put it on the finger and it measures the oxygen saturation. This. Mine happens to be 98%, and this one's pretty cool because it gives a little waveform that is just for looks, really. There is a pulse ox waveform, or an SpO2 waveform, called a PLETH, P-L-E-T-H, and I'll show you that later in the hospital. This is an O2 PLETH. And once you learn to read that waveform, then you don't need the number. But anyway, I'm at 98%, and my caffeine is sort of going away. I'm down in the 80s. Of course, I'm not resting. If I was to lay down, hopefully my heart rate would go back down into the 60s again. But the thing when you measure the SpO2 is it gives a percentage, okay, and it also gives a number, a heart rate. So when you look at this heart rate on here, that heart rate should be very close to the one that you took mechanically, that you counted. So your mechanical pulse, mechanical I mean by touch, okay, so the one that you took, like the radial pulse, should be really close to this number here. If they're off quite a bit, then you can't take this SpO2 reading. This pulse rate has to be close to what you have. This is my second one of these. My first one, somebody liked it better than I did. So why anybody would take a pulse oximeter, pulse ox is beyond me. I don't think any of the students did it. I think it was someone else, but you just wouldn't have a reason to have one of these. I mean, it's not something you hang from your mirror. It's several $100s, so please, when you use the pulse ox, the SpO2 meter, please be careful with it. There's a button right here that you push to turn it on, then you put your finger, and you can sort of see the pad where the button is right there. So check that out. So the norm, we know that the norm is 95 to 100%. All we're learning right now is normals. When we get into respiratory emergencies, we'll see stuff we'll learn how to treat something that's potentially abnormal. So SpO2, partial pressure of oxygen in the capillary bed, you want to get the SpO2 reading before you apply oxygen. Right out to the side here, room air saturation. Room air oxygen saturation. That's what you want. You want a room air oxygen saturation before you put on the oxygen. Otherwise, you don't have what's called a baseline. A baseline in medicine, like baseline vital signs, is where you start from. If you don't have the baseline, then you don't have a point of reference on where you started from. So you don't know where to go from there. It's very important to get a good baseline. So that's the SpO2, the measure of oxygen. Now we're going to learn about our first drug that we're going to administer. Oxygen, right? Oxygen is a drug. Not the oxygen that we breathe here, because room air oxygen is what percentage? 21%, right. 21%. You can have all the room air oxygen you want. This oxygen that comes in here is what percent? 100%, right. This is medical grade pure oxygen. It's 100% oxygen that comes out. When we talk about oxygen delivery, we're really talking about percentage. We're going to try to adjust the percentage of oxygen that's being delivered to the body. So anything more than 21% is supplemental. You supplement the oxygen, right? So this is what this is talking about, is supplemental O2, or supplemental oxygen. It's important that you be able to identify the cylinder because of the fact that they may ask you to go get one. Right? Go get me an oxygen cylinder. If you don't know what they look like, then you might come back with an air cylinder or something. With different cylinders. They have these cylinders, everything comes in here. I could have a diving cylinder full of room air that would look very similar to this, just a different shape and color, right? So when we look at the oxygen cylinder, first we need to identify it. And we identify this oxygen cylinder by the color. They're either completely green or they're green and silver, like this one, completely green or green and silver. The other way that we identify the oxygen cylinder is the label. It says oxygen. All right? Now, there's other uses for oxygen, welding, right? It's one of them. Use oxygen for that. But over here, it says USP. USP stands for U.S. Pharmacopeia. You can just go with USP. But the U.S. Pharmacopeia is a book with every drug, every medication in the United States in it. This being a medication or a drug, it's in the USP. So to make sure that this is medical grade oxygen, green or green and silver, US oxygen, and it says USP on the side of it. Now the other way, the third way to identify it is the neck. Only medical oxygen has what's called a 2-pin index system on it, which means that it has 2 holes here, right? The neck is different. It has 2 holes that these 2 pins on this regulator fits into. So once you have this, hold that up for me, would you? Once you have this, you have the 2 pins there. And these 2 pins fit in to those 2 holes and oops. And you just hand tighten it up here. Alright? And then you put the regulator on it. So the color, red, do that off. Green, completely green or green and silver. You have the label that says USP on it, and then you have the 2-pin index system. And that's what identifies this as an oxygen cylinder. When you look at the regulator on top, if we were to split this regulator open, there's just a big spring in there that helps compress the air. This one had to be empty or I'd show you. But this air comes out. If I was to open this without the regulator on it, and this had oxygen in it, it would come out at 3,000 psi. There's no way that you're going to be able to breathe that. It's like a hurricane in here, right? If I turn this on and pointed the hose that way, you would feel the air all the way in the back of the room. Yeah, you would really feel it. Okay. So this helps compress it. When we look at this gauge, this first gauge here, this tells us how much oxygen is in the cylinder. The oxygen is measured PSI, pounds per square inch. So it tells us the PSI. We won't worry too much about how much is in there right now. And then this dial over here dials up the liter flow. When we talk about a drug, we always have a dose, right? You have a dose of Tylenol. You have a dose of oxygen. The dose is in liter flow, liters per minute, or little letters, LPM. So when you see this, LPM, that's liters per minute. That's the dose. So liters per minute is the dose of oxygen. And this, you just dial this in here. This will make more sense after we can get up and move around and look at it a little bit, okay? So once we look at the oxygen, I'm going to get one that's filled so you can see the difference in the oxygen in there and the meter and the liter flow as well. But right now, I just want to sort of show you the different, to make sure that you're able to identify that that's an oxygen cylinder. You always lay an oxygen cylinder down Never leave it standing up anywhere. You notice I had her hold the oxygen cylinder on. If that was to get knocked over and that neck break off of it, then you have a rocket, right? Oh yeah, big time. So if this was to fall off and hit the ground and this neck broke off, this part right here, the neck, would go what direction? That way. And it's been documented that this has happened before, and they documented that that neck of that oxygen cylinder ended up in several exam rooms. It went through walls. So this would go through that wall without any problem. I'm talking rocket. Now what about the container? What about the cylinder? You think it's going to go that way?
Yes.
Air goes out this way?
Yeah, it's going to push it up.
You think it's going to go this way, don't you?
Yeah.
And it may just for, exactly. It may just for a little bit, and then it's going to start turning. So it's going to start doing this. You imagine that hitting you in the shin? Yeah, it's going to break it. Okay? It's going to cause a major life-changing injury to you if it doesn't get altitude and start spinning. Oh, yeah. So when you see this, never leave it up like this. If you see one like that, perhaps EMS comes in, they set it down, and they forget, you go over and do what's right and take that oxygen cylinder and land it on its side like it's supposed to be. Everybody will thank you later, including the EMS. They'll look over and go, oh yeah, sorry, thanks. Because they know they made a mistake. That oxygen cylinder is supine. Okay, it gets laying flat. That way it doesn't accidentally get knocked over. Very important to remember. All right, let's talk about the first adjunct. Everybody's probably seen these, at least on TV. That didn't work. So much for that. The nasal cannula. All right, or it could be used as a jump rope if you get really bored. Let's see.
Too close. Oh,
Alright, so good cardio workout, or good for oxygen. Alright. This end would go into what's called the tree of the oxygen, or this little thing over here. You don't have to shove it up in there, just a little bit. Keep it on there. Don't push it all the way up. You end up having to cut it off. Goes into the tree, the oxygen tree. If you look over here, I've got a white one. I need to get a green one. Green stands for oxygen. Yellow is for air. So I've got the wrong color tree there, but that's okay. You can sort of see where it would go. This device here is more like what you would see in the hospital. This type regulator here. The nasal cannula, like any delivery device, you're delivering supplemental oxygen. So this is going to aid in breathing. With any medication, you have indications, which would mean that's what it's for, right? Contraindication, which means what? Contra, exactly what it's not for, against. Not too many indications for, contraindications for oxygen. Right? We breathe oxygen. One of my favorite things to do is go into a fast food restaurant. You're up there ordering, and they're behind the times, and they still have the drink thing in the back. I walk up and say, hey, give me, make sure you get easy ice. I'm allergic to ice. If I get too much, I'll have a seizure. And they go, oh, okay. And I've really had them put ice in it, come back and say, is that enough? Is that too much? No, that's fine. If I do have a seizure, my wife knows what to do. Can you be allergic to ice?
No.
Water. You can't be allergic to water. We're 70% water, right?
Oh, you guys.
Okay. So anyway, so you have indications, contraindications. you have the dose. The dose for the drug, 2 to 6 liters per minute. And then what we're concentrating on is the percent of oxygen that this is going to increase above room air. Now don't be like students in the past, because I will make fun of you forever for it. When you see this on the test, and you say the percentage of oxygen for the nasal cannula is 24 to 40%, that's how much it increases the oxygen percentage, or can increase the oxygen percentage, okay? Why in the world would you put 10% there? Think about it. Why would anybody put like 10%?
What do you see?
Because they're making a very, very ignorant guess. Because room air is what? 21%. You keep saying 20, you better bump that up a percent. 21%, 20.9 to be exact. Alright? So 21%, there's no reason for you to fall below that. Even at Mount Everest, the oxygen concentration is still 21%. It's just thinner. The oxygen molecules are further apart. So the percentage that you're going to increase this is between 24 and 60%. You need to know these percentage in this liter flow. Yeah, I'm sorry, 24 to 40%. So the nasal cannula, the indication is mild respiratory distress. The dose is 2 to 6 liters per minute. Now, in all practicality, 4 liters is the maximum dose. If you get 6 liters going up in there, it's going to dry out their nasal passages and then probably start a bloodbath. Medical oxygen is really dry. That's why they sometimes run it through fluid, humidify water, moisten it. So, mild respiratory distress, we'll get into more of that later, of what mild respiratory distress is. Don't worry, I'll define that later. All right? 2 to 6 liters per minute, 24 to 40%. So we're still sort of in the memorization part of this. When we get into the emergency part, learning about the different respiratory emergencies, then we're going to get application to it. The other second device, any questions over the nasal cannula? Everybody good? Okay. The second device is called a simple face mask. They use these a lot during pediatrics. All right? The simple face mask, or it's also referred to as a partial rebreather. Partial rebreather, because you're rebreathing part of your carbon dioxide back and forth. But they don't use these very much anymore, just because of cost. If they don't put a simple face mask on, they usually put the next adjunct on, which is a non-rebreather. So they don't use these primarily due to cost. However, the indication for this, I don't have it written up there, is for mild to moderate respiratory distress. Sort of fall in there somewhere. Mostly in pediatric patients, they use these. You rebreathe a lot of your carbon dioxide back and forth with this. Because you exhale in here and you rebreathe, and there's no devices there for the carbon dioxide to really escape. And plus you have the holes in the side. And then the oxygen tubing on the bottom. The dose is 6 to 10 liters per minute, and the increase in oxygen saturation is from 44 to 60%. Am I good? All these doses and everything, these indications and these percentages, you need to commit to memory. You will see this just all over the place. Quiz after quiz, test. This is what I want you to memorize for the oxygen delivery. Everybody good with the simple face mask? Any questions? The next, and probably the most popular one, besides the nasal cannula, is called the non-rebreather mask. The non-rebreather mask is used for moderate to severe respiratory distress. And you can see this one's quite different. It has the oxygen tubing coming down, but it has this reservoir bag here. Your goal in oxygen delivery with the non-rebreather is to keep this bag inflated. That's why when you see these on TV, they have them in this bag not inflated. Now you can go, look at that. You know, at least they can make it real and put air in there, right, to inflate this bag, because everybody knows that that bag is supposed to be inflated. The goal with this, with oxygen delivery, is to keep that bag inflated. Now this is called a non-rebreather because you don't breathe as much carbon dioxide back in. It should have another valve on this side, but it doesn't. You'll see this outlet valve here. You have outlet valves on both sides, and then you have a valve that's in the middle, right here, just right above the reservoir bag. When you put this on, you breathe in, you go that way. These side valves are forced in and they close off these holes, preventing you to breathe in outside air. This inlet valve here on the inside opens up and you breathe what's in the reservoir bag, which is 100% oxygen, right? So you're breathing in more oxygen, more pure oxygen. You're not getting any mixed gases on the outside, because we have 21% oxygen here and we have 78% nitrogen and a few mixed things together that doesn't make any difference really except for pressures. So we have that. Here, 100% oxygen, correct? So you get the 100% oxygen. When you breathe out, okay, these inlet valves open and the carbon dioxide goes out through the side, and this valve here closes off. So you breathe out, the majority of your carbon dioxide is pushed out to these valves. And then you have the strap that you make a good seal on the face with the nose clamp here. That way it's clamped over the nose. Okay? In a minute I'll let you guys up and we'll look through these, okay? So the non-rebreather. Severe, moderate really, or severe respiratory distress, the increase in oxygen is from 90 to 95%. So you went from the nasal cannula at 24 to 40% to a non-rebreather at 95%, right? That's a big jump. That's a lot of oxygen. That's a solid increase in oxygen saturation. Everybody good there? Any questions over the non-rebreather? All right. And the last one we'll look at is the bag valve mask. And you will become very familiar with the bag valve mask because this is the one, this is our breathing apparatus for CPR. When we look at this, you have the bag, which is this part here, the solid part, bag valve, the valve, you hear the clicking, show it in there. That click is the valve that's inside this neck, and then the mask, bag valve mask, or BVM. Or if I tell you to bag the patient, this is what I'm talking about. You're bagging the patient, or you're breathing for the patient. All right. The indication to use a bag valve mask is severe respiratory distress or respiratory arrest, meaning the patient has stopped breathing. So they're not breathing, they're in respiratory arrest. You need to plug this up to the oxygen at 15 plus liters, 15 to 20. Don't get crazy and put it to 25 or whatever, but 15 to 20 liters. And the goal again is to keep this bag inflated, this reservoir bag here at the bottom on the bag valve mask. In it, depending on the seal of the mask, if you're breathing but if you're breathing like through an endotracheal tube, you could deliver almost 100% oxygen. You still lose a little bit in the transition.